So for patients that are triple class exposed, we do have access in Europe to CAR T-cell therapy. We also have access to bispecific antibody. So when we need to choose between CAR T and bispecific antibody, we want to make sure we are choosing the right target, BCMA or GPRC5D, as we have access to both GPRC5D and BCMA targeting bispecific antibody. So I think we do take into consideration, of course, access. Access is not exactly the same across all Europe. Some countries have access to bispecific, some countries to bispecific and CAR T-cell therapy. So access is still something we have to work on to make sure that all patients will have access equally to both CAR T and bispecific. In terms of patient characteristics, indeed, there is fitness. We know that there are differences in terms of immediate adverse events, CRS, ICANS, between CAR T-cell therapy and bispecific antibodies. The rate of CRS, particularly and neurotoxicity, is a bit lower for patient receiving bispecific antibody as opposed to patient receiving CAR T-cell therapy. On the other hand, also disease characteristics. We know, for example, that for highly proliferative disease, CAR T-cell therapy may be very active, but not every patient will have the chance to and the opportunity to wait for 1 month or 2 months for CAR T-cell therapy manufacturing, particularly for patients that are highly pre-treated and for whom we don't have many bridging therapy options. So for those patients, probably patients also with cytopenia, bone marrow invasion, bispecific antibodies may be a more optimal decision. Indeed, the treatment-free interval provided by CAR T-cell therapy, especially for young patients, is very, very appealing.